Welcome all to this topic. So we will be discussing something about the cardiovascular symptom analysis today. So basically this session is aiming at a third sem MBBS student who is entering the clinics and who is learning how to take a proper history. And as you know, history is the most important part of a diagnosis in medicine. So history forms the crux, and if you only know how to take a proper history, you will be able to reach the differential diagnosis the patient is having and finally reach at a possible diagnosis. So going into the cardiovascular symptom analysis, the main symptoms are, as you see, you have the chest pain, breathlessness, palpitations, syncope, fatigue and edema. The thing you have to know is that even though these are the cardinal symptoms of the cardiovascular system illness, many of the symptoms can be due to other system as well. So first of all, for example, you know that a patient with a COPD or bronchial asthma can present as breathlessness. So the symptoms may not be truly related to cardiovascular system, but these are the cardinal symptoms of a cardiovascular system illness. So we will try to analyze each of these symptoms so that you have an idea how to approach to these symptoms and reach at a differential diagnosis in a patient. So next thing, after you are learning that various system diseases can cause similar symptoms like a cardiovascular system illness as well as a respiratory system illness causing breathlessness as a symptom. Inside the cardiovascular system itself, we have numerous classes of diseases. For example, you can see there may be an ischemic heart disease, valvular heart disease, congenital heart disease, cardiomyopathy, myocarditis, infective endocarditis, cardiac arrhythmias. Similarly, other diseases like rheumatic fever, pericardial diseases, hypertensive heart disease, disease of great vessels. Also, even systemic diseases which can have cardiovascular manifestations like anemia. So, all of these classes of cardiovascular symptoms can have overlapping symptoms. For example, as you know, ischemic heart disease is one of the classical one that presents with chest pain. So chest pain, whenever you hear of chest pain, you think that it is a myocardial infarction or ischemic heart disease. But the chest pain can be due to various other diseases as other classes of cardiovascular system diseases as well. So first of all, important thing is to identify whether this is a cardiovascular system illness or not. Then the second step is to identify which all classes of cardiovascular system disease is present in this patient. For example, an ischemic heart disease patient like a myocardial infarction patient can have coexisting mitral valve disease because of the ischemia. So here the two classes like the ischemic heart disease as well as the valvular heart disease is coexisting. So many such classes of cardiovascular system diseases can coexist in a similar single patient and may result in various symptoms. So we have to identify that fact also when you are going to analyze the history. So this is the thing that I meant. You can see that all of these symptoms, for example, a valvular heart disease may be caused by, this is a valvular heart disease, and it may be caused by ischemic heart disease, a congenital heart disease, infective endocarditis, cardiomyopathy, myocarditis or rheumatic heart disease. All these things can lead on to valvular heart disease. Similarly, an arrhythmia may be caused by valvular heart disease, congenital heart disease, myocarditis, ischemic heart disease, etc. So numerous classes of cardiovascular system illness, one can lead on to the another, and that may result in various symptoms of the cardiovascular system illness. Now we are going to analyze the symptom called chest pain. Okay, so chest pain, as you know, is a pain that is originating from any part of the chest. So we can divide this chest pain into different classes based on how you are understanding the symptom. Like first important classification is the central versus peripheral chest pain. Okay, so pain can be originating from the center of the chest or it may be from the periphery of the chest. You may be remembering the anatomy of the mediastinum, in which almost all structures of the mediastinum are situated in the center of the heart, in center of the mediastinum, like the heart, pericardium, the great vessels, trachea, bronchi. All these things are situated in the center of the chest, while the periphery of the chest contains lungs, pleura, the neurovascular bundle, ribs, chest wall, and the skin. So this is how you identify the central versus peripheral chest pain. So naturally, when a central chest pain comes, you can think of the structures present in the center of the chest, and that may be one of the cause of the pain. While in the peripheral pain, you can think of the structures in the periphery of the lung, periphery of the chest. Now, another way of dividing the chest pain is acute versus chronic. Like a patient coming into the casualty with a short duration of severe chest pain, the diagnosis may be different from a patient who is coming with a history of long duration of chest pain that is originating from the back or the side of the chest. So that in that way also you can differentiate chest pain. The third method is a physiological differentiation, that is regarding somatic and visceral. And as you know, somatic pain, basically somatic means it is a superficial pain, isn't it? Somatic pain is a superficial pain. So the pain is usually arising more superficial, and the patient will having local tenderness, and the patient may point towards the site of the pain, while the visceral pain, on contrast of that, the visceral pain is usually non-localizable. It is arising from the viscera, though the patient cannot localize where exactly the pain is. It may be a vague sensation over the chest, associated usually with a nausea, vomiting, like symptoms may be associated. And also the patient they are unable to say exactly from where the pain is arising. And another last practical way of differentiating the chest pain is regarding a cardiac pain versus a non-cardiac pain. So this classification is very important, because whenever you are sitting in a casualty, sometimes recognizing a cardiac pain early itself and giving the appropriate management sometimes may save the life of the patient or may give quality of life to the patient, because you can prevent something like a left ventricular dysfunction in a myocardial infarction. So it is worthwhile identifying the pain as this way also, like a cardiac or a non-cardiac pain. Now this is actually to give you an idea regarding which all diseases are presenting as chest pain in a casualty. Okay, you can study this. This is a distribution of final discharge diagnosis in a patients with non-traumatic acute chest pain. Okay, so that is where the medicine comes. The patient comes into the casualty with acute chest pain. The study shows that the most common cause of chest pain was gastrointestinal, accounting for about 42%, like a reflux esophageal disease or an upper GI upset, which is mistaken for a chest pain. And the second important cause comes the ischemic heart disease, 31%. And next, third was the chest wall syndrome, so like the non-cardiac pain, like the superficial costochondritis or arising from the muscles or the joints. And the rest of the all causes of chest pain comes as only a minor percentage. So this gives an idea that practically the causes of chest pain that when you see in a patient with in casualty, most often it may be either cardiovascular, you have to rule out cardiovascular, then it may be gastrointestinal, or it may be a chest wall disorder. Now this is how you classify the causes of chest pain. You can see this, and basically the classification is based on what I have told earlier, like a central versus a peripheral chest pain. Now central chest pain, as I have told, there are numerous structures in the mediastinum, and the first and foremost pain is the cardiac pains or the ischemic heart disease. So that's the most important thing you have to identify, because that is a potentially life-threatening condition. So you have to identify that immediately and to give appropriate treatment for that. Next, it may be a pericarditis or a myocarditis, because as you can imagine, the pain is arising from the heart only, and the pericardium is surrounding the heart, so it may also mimic a central chest pain. Now, valvular heart disease rarely can present as chest pain only because of the chamber hypertrophies, like a left ventricular hypertrophy resulting in a valvular heart disease can result to chest pain. And finally, the other central structures like aorta, or pulmonary artery, where you have aortic aneurysm, aortic dissection, or pulmonary embolism, all these can be considered as almost a cardiac pain. Now, the non-cardiac pains, in fact, pulmonary embolism, even though it's a central structure, it is related more towards the lungs, isn't it? So the pulmonary embolism can be considered as a non-cardiac pain. Also, the esophageal disease, the patient may complain of burning esophagitis or reflux esophageal disease. This can also present as a central chest pain. The third cause is the costochondritis. Even though it is a peripheral structure or a somatic pain, it is situated in the central on either side of the sternum. So the patient may be complaining the chest pain because of costochondritis, and this can be also considered as a central chest pain, but it is non-cardiac in origin. Now, the peripheral chest pains, whenever you think of a peripheral chest pain like on the side of any part of the chest, immediately the thing that comes into your mind is regarding the lungs or the pleura. So any disease of the lungs, for example, a pulmonary infarction or a pneumonia or a pneumothorax, all these things may present as a peripheral chest pain only, or even it may be a lung malignancy also. And the non-pulmonary causes are regarding the chest wall or the rib. For example, a rib fracture or a herpes zoster in the skin, all these things may lead on to a peripheral chest pain. So this is how you practically classify the chest pain into central and peripheral first, and in the central you can divide us into cardiac and non-cardiac, and the peripheral you can divide into pulmonary and non-pulmonary. So that is how you practically classify the causes of chest pain. So this is a diagrammatic representation of the various causes of chest pain. So this is to give you an idea regarding the causes of the central and the peripheral chest pain. So in the center you can see the heart is situated in the center, and all the ischemic heart disease, like a pulmonary embolism or a esophageal disease, all these things, aortic dissection, everything comes in the center. So this is comprising the central chest pain, while the peripheral chest pain is regarding the lungs, that is a pneumonia or a malignancy, or a patient is having a rib problem, rib fracture or herpes zoster, all these things comes as a peripheral chest pain. So this will give an idea regarding the anatomical structures that is situated in the center and periphery, and get an idea what all structures are causing the person chest pain. So the most important type of chest pain you want to identify is a cardiac pain, otherwise called angina, because this is the most important life-threatening condition and the most common life-threatening condition with which a patient presents to you with chest pain. So the most important thing is to identify what is an angina and how will you identify an angina. Most often the classical presentation, like a patient is coming, as in the picture that you can see, the patient is coming with hands clasped towards the chest, saying that I am having a central chest pain. So this is a classical presentation where you describe it as called the Levin sign, but sometimes the patient may not always present like this. So let us see what are the cardinal features of an anginal pain. First of all, the anginal pain is usually a central pain. So first of all, you are considering angina typically in a central chest pain. Now the second feature is that this pain is usually a visceral origin, so the patient will be having a typically retrosternal crushing sensation or heaviness sensation. So it's like a heaviness, or it can be also sometimes described as a tightening sensation or a weight in the chest. So in that way also you can describe an angina. The third feature is that usually it may radiate to other areas of the body. For example, the typical classical radiation is described as towards the left arm, but it can also radiate towards the right arm as well. It can radiate to the epigastrium, as well as it can even radiate to the jaw. So these are the areas where you can get a radiation of the angina. So the third important point is the radiation of the pain, typically into the characteristic sites. The fourth point is that the pain is usually associated with the characteristic features like nausea and vomiting and sweating. So there is coexisting autonomic symptoms. So coexisting autonomic symptoms are the next finding associated with the nausea, vomiting and sweating. So whenever you are dealing with a patient having a central chest pain radiating to the arms or the jaw or the epigastrium, along with a described as a heaviness or tightening or constricting sensation, along with autonomic symptoms, it is very classical that you are dealing with an anginal pain or a cardiac pain. Now the problem is that all patients may not be presenting like this. The many patients can have atypical presentation. So the two things you have to understand, that all chest pains are not angina, which we have already described, and also all anginas may not present with the typical characteristics which we have now described. Sometimes the patient may present the atypical manifestations. All the patients may not be presenting with these characteristic symptoms. Some patients may present with other symptoms which are called as anginal equivalents. So first of all, we have to identify what are the anginal equivalents. So thing is that anginal equivalence means these symptoms can be considered similar to angina in an appropriate setting. For example, the classical symptoms are the patient may presenting with a dyspnea. So that is another cardiovascular cardinal symptom, but the patient with ischemic heart disease instead of angina may present with the dyspnea only. Okay, so that you have to understand that sometimes an ischemic heart disease may be presenting with dyspnea only. That is a fact you have to understand. The second symptom is the patient may present with syncope, like the patient is suddenly collapsing somewhere and the patient may be having an ischemic heart disease. They may not even complain of chest pain. Third symptom is palpitations, and the palpitations are usually associated with some arrhythmias or some bradyotachyarrhythmias happening along with the myocardial infarction. And fourth one is an extreme fatigue. Usually following an exertion, if the patient is having an extreme fatigue associated with the sweating, nausea, etc., without chest pain, even you can consider this as an anginal equivalent. So here these we consider in certain patients who may not have typical features of chest pain. For example, they have something like a diabetes coexisting, which is there is a coexisting autonomic dysfunction is there. So the patient may not be presenting with the characteristic pain. So there may be a without pain, the patient may present with angina. So that is an important thing you have to understand. Similarly, there are certain atypical symptoms or atypical presentation of angina as well. Let us see what are those. So the patient may present with a lot of atypical symptoms, like they may present with isolated jaw pain. They may present with jaw pain only. They may present with arm pain only, or they may present with atypical sites like back pain, which is usually mistaken for some other cause, but sometimes it may be due to an ischemic heart disease. So the patient may be having a back pain also, or the patient may complain of sometimes of dyspeptic symptoms. Like the patient may be having most of the time they will say that I am having gas or something like that, and it's easily mistaken for peptic ulcer disease or reflux disease, and it is mistaken for, and the myocardial infarction is usually missed. So in this way also you can get a presentation, atypical presentation of ischemic heart disease. Or the patient may have sudden severe sweating or lightheadedness or faintness. All these symptoms the patient may develop sometimes as a manifestation of ischemic heart disease. Then there is an important entity called the postprandial angina. Here the patient usually complains of anginal pain following a food intake. And since it is following food intake, most of the patients, what they try to attribute the pain towards in relation to the food, so that they will mislead you from the diagnosis of ischemic heart disease. But if the anginal pain, any characteristics of anginal pain is present in such patient following a food intake, that means it may be a postprandial angina, and that is suggestive of a significant cardiovascular disease or a coronary artery disease. So you should not ignore such a symptom following the food intake, because it can be postprandial angina as well. Now, on this background, let us try to analyze the history. See this, a 60-year-old male, a chronic smoker, diabetic and hypertensive for the last 5 years, is presenting with acute onset severe fatigue for 30 minutes following an exertion, associated with the nausea, vomiting and sweating. So thing you have to notice that there is no chest pain here. Even though we are discussing about angina, there is no chest pain here. So will you diagnose or will you suspect an ischemic heart disease in this patient? So that is a question. So what I intend to say that all the patients may not be presenting with typical angina. So this is a case where the patient is having no chest pain, but is having some anginal equivalent. Okay. Now, how to diagnose an angina, how to diagnose a ischemic heart disease in such a patient depends upon what is the type of patient that is presenting to you, or who is the patient in front of you. You can see that the patient is a 60-year-old patient. So a 60-year-old, that means the chance of ischemic heart disease is high, because as the age progresses, atherosclerosis develops and the patient may be having high chance of developing ischemic heart disease. Second point is that it's a male. Actually, you know that male and the male sex is having a increased chance of developing ischemic heart disease compared to a female sex of the same age. Especially in premenopausal age groups, it's always the male sex is having a more chance of developing ischemic heart disease. Postmenopausal, it is almost equal or more in males and females. Now, you can see there are some more risk factors are there. The patient is a chronic smoker, a diabetic and hypertensive. So we have some risk factors here. So you have to always assess the risk factors in this patient. Like here the patient is a smoker. As you know, smoking is an important risk factor for developing ischemic heart disease, as well as type 2 diabetes mellitus and the hypertension. So both of all these things are risk factors. So now if a patient with multiple risk factors presents to you, and the patient even if the patient is not complaining of a typical chest pain, you have to rule out ischemic heart disease or an angina. So this is the thing. So the who is presenting of the symptoms is much more important than the symptoms per se. Okay, so the patient presenting the atypical symptoms, if the chance of ischemic heart disease is high because of his risk factors, then definitely you have to evaluate that patient. Otherwise, you are going to miss a ischemic heart disease. So now, to understand this point in detail, we will see what are the risk factors of acute coronary syndrome. So here you can see that there are non-modifiable risk factors as well as modifiable risk factors. Okay, non-modifiable means you cannot change that. Like an age or sex or family history, you cannot change because that is present and that will not be changed. While the modifiable risk factors are the diabetes, hypertension, obesity, smoking, physical inactivity and dyslipidemia. So all these symptoms, all these risk factors, if the patient is having, naturally there is a high chance for acute coronary syndrome. So you have to understand the fact that who is presenting with these symptoms, with a person with risk factors is having more chance of developing angina compared to a person who is not having any risk factors. So now a patient who is presenting with chest pain as angina most likely is having a acute coronary syndrome. Previously we used to call it as myocardial infarction. Now the present term is acute coronary syndrome. Now the acute coronary syndrome, whenever you are dealing with an acute coronary syndrome, like you have understood that this is a case of possible acute coronary syndrome from the history, now you will immediately take an ECG and see whether the patient is having something like an ST segment elevation in the ECG, or if there is no ST segment elevation, like there may be other changes like ST segment depression, or there may be a T inversion. So the patient may first take an ECG and see whether it's an ST segment elevation or there is other features like an ST segment depression or T inversion. If you have an ST segment elevation, you call it as an ST elevation MI. If there is no ST elevation, you call it as non-ST elevation MI. The newer term are non-ST segment elevation ACS and ST segment elevation ACS. Okay. And in a case of non-ST segment elevation ACS, you do the cardiac biomarkers like the troponins, and if it is negative, you call it as unstable angina, and if it is positive, you call it as myocardial infarction. Okay, so that is how you differentiate the different type of ACS. I just described that for the sake of identifying this, because it's very important to identify an acute coronary syndrome in a casualty. The other variant we will be discussing is a chronic stable angina. Here the thing is not an acute presentation. Here the patient presents with a chronic chest pain, and the pain is characterized by the fact that while the patient walks or exerts or climbs, the patient develops chest pain, but this is usually a duration of the pain is less than 10 minutes, and this when the patient takes rest, it subsides, and the pain recurs when the patient exerts for the second time. So that is the characteristic feature of unstable angina. That's angina on exertion. It's lasting for about 5 to 10 minutes and is relieved by rest or nitrate. So that's a classical feature of a chronic stable angina. So we have to know that fact that chronic stable angina not always means it is an ischemic heart disease. So it is only one of the reasons. Coronary heart disease is only one of the reasons for chronic stable angina. But a valvular heart disease like an aortic valve disease, the aortic valve disease, what happens is that there is a chamber hypertrophy. Whenever there is an aortic valve is stenosed, what happens is the left ventricle below that becomes enlarged, and there is a demand supply mismatch because the left ventricular muscle mass is much more now, and that results in angina. So this should be ruled out because before sending for an coronary evaluation, because this can also present as a chronic stable angina. Another thing is that anemia or a hypertrophic cardiomyopathy can also present with angina, chronic angina, because of the increased muscle mass or the decreased hemoglobin content. Comparing to the stable angina, now we are discussing unstable angina, how to identify an unstable angina clinically. So the features of unstable angina is that first one is the angina occurs at rest. I already told that chronic stable angina only occurs during exertion, while here the unstable angina, the pain starts in rest. Whilst resting, the patient can have chest pain. Also, if the patient is developing chest pain on exertion and is not relieved by rest, so that's the second point, the chest pain is not relieved by rest, and the duration is usually more than 20 minutes. So the pain goes on. Unlike a stable angina, the pain goes on and is not relieved by rest. This is classical of an unstable angina. And any new onset angina, so if a patient is developing angina for the first time, it should be considered as an unstable angina. And also a patient who is complaining of chest pain in the past, now he is complaining of increasing severity or increasing frequency of chest pain, that should be also considered as an unstable angina. Or it may be a chest pain following a myocardial infarction. Patient who history of myocardial infarction in the past, and within 4 to 6 weeks now the patient is complaining of chest pain again, it should be also considered as an unstable angina, which is called the post-infarction angina. So these are the characteristic features of a unstable angina. So clinically itself, by taking the proper history, it is easy to identify whether the patient is having an angina, and if the patient is having an angina, from the history you can differentiate whether it's a chronic stable angina or an unstable angina or even a myocardial infarction, even though you may require help of ECG as well as the troponin I markers. Now coming to the after the angina, the second important type of chest pain you have to deal is pericardial pain. The thing is that the pericardial pain is also central in origin, so, and it may confuse you sometimes because of its site of origin. Now, pericardial pain, the importance is that how to differentiate from an ischemic heart disease angina is that usually the pericardial pain is the acute coronary syndrome pain presents as sudden in onset, while pericardial pain usually it will have a hours or days like presentation, and it's usually a characteristic of pleuritic pain, like it increases on breathing or increases on deep inspiration, the pain gets increased. Also, the pain is retrosternal. It can be referred to left shoulder because of its because of the diaphragmatic irritation and the common nerve supply towards the shoulder. And the characteristic feature of the pericardial pain is that it is relieved by sitting and leaning forward position. So, this is an important history. If the pain is a postural change, like the patient is sitting and leaning forward and the pain is getting relieved, that is a characteristic feature of pericardial pain. And this is totally not present in an angina due to myocardial infarction. And on examination, you may get something like a pericardial rub. There is a particular sound that is heard due to inflammation of pericardium, and the pericardium rubbing, inflamed pericardium rubbing towards each other produces a pericardial rub that may be auscultable. And sometimes the problem is that the pericardial pain or the pericarditis can produce ST segment elevation in the ECG. So, see, you can see how easy to mimic a pericardial pain for a myocardial infarction, because it is both are central, both can have features suggestive of severe pain, and the both can have ECG changes, similar ECG changes as well. So, it is very important to differentiate the pericardium because the management is entirely different. So, it is important to identify a pericardial pain from the history. Next is another important cause of a central chest pain is pulmonary embolism. Even though it's a non-cardiac, said to be non-cardiac, but it's closely related to the heart as well. The pulmonary embolism is almost always sudden in onset. So, the most important point that helps you in identifying a pulmonary embolism is its abruptness in onset. That just before that moment, patient is okay, all of a sudden patient will have central chest pain, and there may be associated features like patient may be having a hypotension feature, so there's a drop in blood pressure, or the patient may develop syncope like episodes, and the patient is having a chest pain. Usually the patient, because of this pulmonary perfusion is affecting, the patient may be having coexisting dyspnea as well. So, there is a dyspnea and chest pain will be the presenting symptom if it is a central pulmonary embolism or a major pulmonary embolism. And on examination, you will get a characteristic triad called the tachypnea, tachycardia and hypotension. If it is a massive pulmonary embolism, that is, you can see in this picture, the embolus is coming from the distal vessels and is finally lodging into the lung. So, if you have a embolism like obstructing here, what happens is that the blood circulation to the lung is affected. This results in hypotension, and the patient will be having coexisting tachypnea, tachycardia as well. So, this triad gives an important clue that the patient is having a pulmonary embolism. But sometimes the pulmonary embolism may be in the periphery, like a periphery. So, you will get only a small area of infarct in the periphery of the lung. In that situation, what happens, that patient presents with a pleuritic type of peripheral chest pain. So, there is a difference between the type of pulmonary embolism and the presentation. If it is a central the massive pulmonary embolism, patient may present with central chest pain, dyspnea, tachycardia, tachypnea and hypotension, while a peripheral pulmonary embolism usually presents as a peripheral pleuritic chest pain. The next important differential diagnosis you have to consider in chest pain is acute aortic syndrome, like what happens in an aortic dissection, something called the aortic dissection. So, you can see this picture shows there is a false lumen that is created in the aortic wall. So, you can see the aortic intima there is a tear in the aortic intima, and the blood enters the aortic media and creates a false lumen, and this produces a swelling of the aorta, and it may obstruct the, suppose there is an artery originating from this position, automatically this false lumen obstructs this blood flow, and there is a decreased blood flow through the peripheral artery, and that may present as absence of pulse in that particular area. For example, you know the aortic arch, in the aortic arch you have the carotid arteries as well as the subclavian artery coming. Okay. So, if there is a dissection of the aorta which is involving this area, it will obstruct the blood flow to this artery and may result in absence of pulse in that limb. So, that is an important feature you have to identify. The pain is characteristically described as a tearing, acute, severe pain, which is usually radiating to the back of the thorax. That is because aortic arch is going posteriorly towards near the vertebral column. So the pain is usually referred to a back of the chest, as well as the patient may be having features like absence of pulses. That is because it is obstructing the blood flow to the arteries. The patient usually patient will be a hypertensive patient, or patient may be having diseases affecting the collagen, and this can affect the aortic valve as well and may result in valvular lesions like aortic regurgitation. So now coming into the next type of pain, that's a pleuritic chest pain. Now the pleuritic chest pain can be usually a peripheral chest pain. Usually it is a peripheral chest pain, but it is associated with the pericarditis. Sometimes it may be a central chest pain as well. Now the characteristic feature of pleural chest pain is that whenever the lung expands and contracts, the pain aggravates. So like when the lung expands and the structures that moves produces aggravation of this pain. So the characteristic feature is that pain on deep inspiration. When ask the patient to take a deep inspiration, and if the pain is increasing, that means it is likely to be a pleuritic pain. And usually it's a catchy type of pain, and the patient suddenly winces because of the inflamed structures rubbing together. That results in the pleuritic pain. Now you have to understand what are the structures that is moving inside the lungs. For example, when the patient takes a deep inspiration, the chest wall moves. Okay, the chest wall expands and contracts. When you are dealing with a pleuritic chest pain, you have to understand what are the structures that is moving when the chest expands. So in the chest wall, you have the pleura, you have the muscle, that's the intercostal muscles, you have the bone, that's the ribs, and you have the intercostal nerves and vessels, as well as the cartilage. All these structures are basically moving when the patient is having a pleuritic chest pain. So basically a diseases of the pleura. So first one is a pleural diseases like a pleurisy or a pleural effusion can have a pleuritic chest pain. Second one is the diseases concerning the ribs. For example, a rib fracture or a lytic lesion in the metastasis in the rib, etc. can have a produce a pain while movement. So that can also mimic a pleuritic chest pain. Third one is the disease affecting the muscles or the nerves. So anything affecting the muscles of the nerves in the chest wall can also present as a pleuritic chest pain. Fourth one is the next you have the cartilage, that is a costochondritis. Costochondritis can also present as a pleuritic chest pain. So all these structures, when that moves during the inspiration or deep inspiration, can present as a pleuritic chest pain. So even though we are considering all these, the most common cause of a pleuritic chest pain is a pleural disease. So whenever you are dealing with a chest pain that is increasing on deep inspiration and it's a catchy pain, it is characteristic of pleuritic chest pain, and the most important cause is a pleural disease. You have to consider diseases like pleural effusion, pneumothorax, or pleurisy when you are dealing with a pleuritic chest pain. But remind you, all other structures that moves like the ribs, intercostal nerves, muscles, everything can produce the pain mimicking a pleuritic chest pain. The next important cause of chest pain you have to deal with is gastrointestinal. As I already told you, one of the important presentations or important causes of chest pain in a casualty is gastrointestinal. So even though the gastrointestinal structures are present in the abdomen, a reflux esophageal disease or an acid peptic disease, coexisting esophagitis, all these things can come with chest pain, and the patient may say that I am having a burning sensation in the chest, and now we have to differentiate between an ischemic heart disease and a peptic ulcer disease or a reflux esophagitis. So that's also an important, you have to differentiate between these 2 points. And the reflux esophagitis is most often related to the food intake, like either the patient is having delay in food intake or immediately following a food intake, or increasing with the spicy food items, recurrent belching and nausea, vomiting. All this may be associated with this reflux esophagitis or a peptic ulcer disease. So you have to carefully differentiate these symptoms from the ischemic heart disease symptoms. Another important cause which you may miss is a skin disease, for example, a herpes zoster. So you can see this in this picture, you can see the grouped vesicles, very characteristics of the herpes zoster. And if you are not examining the chest wall by exposing the clothes, then you may miss totally this lesion. Sometimes the patient may not complain of this lesion, and you may miss this as something like an ischemic heart disease, and you may miss the lesions. So always, if your thing is a superficial pain, his patient is telling that it's a superficial pain, and always ask for any changes in the skin and expose the chest wall and examine for any lesions like this. Usually it's a prolonged, sharp, burning type of pain, and the lesions you may see like this. Sometimes it can produce even, the pain may persist even after the lesions have healed. Something called the post-herpetic neuralgia can also sometimes confuse you as a chest pain.